Now it's my pleasure to move ahead and talk about the Smi Advisor and talking about long-acting injectables, antipsychotic medications, evidence-based guide to policymaking. First, we're going to have Amy Cohen, who is the program director of the American Psychiatric Association. She's over the Smi Advisor, and then we'll have Ravin from Nevada talking about the long-acting injectables. For those of you who aren't aware of the Smi Advisor, this is a great application, great tool, and it's really a pleasure to have NASMHPD support this effort. So Amy, Dr. Cohen, do you want to go ahead, please?
Thank you so much, Brian, for the introduction. So I'm really happy to be here today joining you on your final week of this meeting, and I really enjoyed the talk that we just heard. I'm going to talk to you a little bit today about our program Smi Advisor. And next slide. The clinical support system for serious mental illness is what we call Smi Advisor. It's funded by SAMHSA and implemented at the American Psychiatric Association. I'm a clinical psychologist directing this project. Next slide. I have nothing to disclose and no conflicts of interest. Next slide. So why did SAMHSA fund this program? They really had a vision to have an overall project that would really try to transform care for people who have serious mental illness so they can live their best lives. And I know that I'm speaking to the choir here. Everybody on this call is trying to do this kind of work, and we're hoping to support you in those efforts. Next slide. We're a national initiative serving really clinicians and providers across all mental health practice settings. And we focus on the disorders bipolar disorder, schizophrenia, and major depressive disorder. I think we would all agree on this call that we might think of serious mental illness in a broader sense and might include other disorders, but this is our mandate from SAMHSA that we focus on these three disorders. Next slide. So when I say that we serve the mental health team, I think of that team broadly. I think of the physician, nurses, psychologists, licensed counselors, social workers, the family, and peer specialists. Next. Next. It's a little bit harder when you're not presenting. Thank you. Well, go back. Just one slide, just one, there we go. So we offer really three assets to the field. One is accredited education on evidence-based practices. And I'm going to talk about the accreditations we do now, but as I go through this, remember, everything is free. I can't say that enough, free. So we have accredited education. We also vet resources. So we know that everybody knows how to Google and Bing and look at everything. What we do is we take resources that are given to us by our partners, including NASMHPD, and we also look for resources, and then we vet them through our clinical team so that two experts in these disorders look at every single resource before it's put in our knowledge base. So you can know that what you're looking at is applicable to SMI, is applicable to frontline staff, and is of recent evidence. Lastly, we provide direct consultation to clinicians, and I'm going to talk about that in a minute, but what I mean by that is we have at our website where you can put in any kind of consult, and we will answer you within 24 working hours. So I just want you to know that all three of these assets I'm going to go to in detail are free to the field, and we would love to hear from you. Next slide. So it all sounds good. How do you contact us? How do you find us? Well, there's two ways. One, we have a website, smiadvisor.org. We've had over 1 million visitors to our website so far. We've existed for 3 years. We're just beginning our 4th year this summer. We also have a free app that's available both for iOS and Android platforms. free in the App Store, or you can find it at smiadvisor.org/app. And this allows you to have access to the resources, put in a consult, or watch a webinar from your phone, which is really nice because I know some of us work at sites where our county or city or state block a lot of things on our work computer, and we have a break or a lunch break, and we could look up some things then. You can always use your phone, your Smi Advisor app on your phone. The other advantage to the phone is we have some gold standard assessments in there, including the PHQ-9, the GAD-7, the DAST, the PROMIS, the AIMS, and you can score them in real time, and it interprets the score and gives you an interpretation of that in real time. So you could use that in a clinical encounter. So that's a real advantage of the app, one, having it in your hand, but also these gold standard assessments. Next slide. Let me go through the 3 assets that we have, and I'm going to start with our educational catalog. Next slide. So when you visit us, you'll look into our catalog or our calendar. Next slide. Our catalog has everything that we've ever provided, and you can go to any one of these webinars and get your CE credits now at any time, asynchronous. We also have a calendar which tells you live ones that are coming up. What's the advantage of doing it live? Well, you get to ask questions to the person who's presenting. What's the advantage of looking at it in the catalog? You can do it whenever you want. So we've delivered over 200 webinars or online modules so far, and trained over 42,000 clinicians. And I just show you a little snapshot I took of our catalog before when I was putting these slides together. For example, bipolar and alcohol use disorders, break the magnetic force, or leveraging knowledge of Clozapine's pharmacodynamics. So there's a lot of different things in the catalog. We offer CME on everything. And when applicable, we offer nursing credits, we offer psychology credits, and we offer social work credits. And we've actually found that social workers are one of our biggest audiences. I think there's a lot of reasons for that. I'd love to say it's because we offer a lot of things that are appealing to them. We also offer free credits, and they need the most CEs of all the disciplines. So they're a great crowd, and we really enjoy having a large group of them, but we really welcome all the disciplines. Next slide. We also have virtual learning collaboratives. Last year, we offered 20 of these, 10 in the fall. We have 10 going right now, and 10 in the spring. These offer you a deep dive on a topic in particular, and they work on something that they can bring back to their clinic. So this is a really nice way to bring something back. Next slide. Next slide. Oh, these are the older slides. Sorry. Keep going. These are some Clozapine ones I wanted to lead into Dr. Levin. Next slide. All right. Let me talk to you a little bit about our resources. Next slide. So as I mentioned, we have over 1,000 evidence-based resources in our knowledge base. These are all vetted. You can search by keywords, or you can see we also group them by topic. A few topics you can see here: manualized psychotherapies, peer specialist, Clozapine. Next slide. We also, I want you to know, develop new resources as well when we see gaps in what resources are available, or if there are resources that have evidence that's too old. One of the new ones we developed this year with the SPRC is the suicide and serious mental illness paperwork, sort of talking you through how to assess for that, what to do, and what kind of prevention resources are available. Next slide. One thing that I'm sure you would not be surprised about is that we developed a microsite during the COVID pandemic. And I'd love for you to visit us. We're at smiadvisor.org/COVID. And we've developed a lot of resources as things have rolled out. So for example, you can see here, we had one about how to talk about vaccines. We had one about reopening your mental health practice. We have some on how to bill for telehealth. We have some on a handout for patients about how to prepare for your telehealth visit. So lots of resources here at /COVID. Next slide. Next slide. All right, consultations. This one is something that I think is of, is being used more and more, and I think it's a great resource for, next slide. So when they go into the website, there's two tiles. There's one for clinicians and there's one for families and individuals. Once you go in clinicians, you can find the knowledge base, the resources, and also consultations. Next slide. Next slide. I'm sorry, these are older slides. I'm sorry, we're not showing the most recent slides. Let me tell you about consultations. We've answered 2,200 consultations so far. Many of them are on psychopharmacology, but many of them are also on psychotherapies, system reorganization, billing, etc. So feel free to reach out to us. Next. I wanted to let you know we have 2 centers of excellence, and I know that Dr. Ravin is going to talk about Clozapine and LAIs in a minute, along with some other medications, but just to let you know that we do have microsites on Clozapine and one on long-acting injectables. Next slide. And each of these have tools, resources, and educations specifically on these topics. Next slide. We have a Center of Excellence Exchange, which is a listserv where people share information and ask very complicated psychopharmacology questions around using these medications. There are nurses, a psychiatrist, and a pharmacist who lead these calls. Next slide. We also have a virtual forum where we meet every month to talk for 30 to 45 minutes, low barrier to entry, where you can bring questions forward and get answers verbally rather than looking through the listserv. Next slide. I didn't get a chance to show the slide here, but let me just say something about where we're going. One area that we really want to move into is more work in rural communities. And I know people on this call oversee areas that have rural communities. And we had some work that we did over the last year led by NASMHPD and NRI to really help us identify where we can make some inroads in those communities. If you oversee one of those communities and you would like some help in that, Smi Advisor would like to partner with you to work on that. And we've really got a roadmap from NASMHPD about some of the things we need to be doing. There was a work group behind that and several individual interviews that really led to that roadmap. So we'd like to partner with you on that. I will leave it at that. And I appreciate the opportunity to talk with you today. Please visit us at smiadvisor.org. Thank you.
Thank you, Dr. Cohen. And now it's my pleasure to introduce Dr. Leon Ravin. Leon, please go ahead.
Please let me know if you can see my slides.
All good.
All right. Thank you for the opportunity to share the scientific evidence of the effects of using LAIs in treatment of patients with schizophrenia. I have been providing education on long-acting injectable antipsychotics as a member of Smi Advisor LAI work group for about 2 years now. And today my goal is to make sure that you have the tools you need for drafting policies affecting care of patients treated with antipsychotic medications, even if you yourself are not going to write a prescription for an antipsychotic in the foreseeable future. I also want to apologize for rushing through some of the slides, but I was assured that you will have access to them after this presentation. And I also have my contact information on this slide and on my last slide. So if you want to learn more about the efficacy of long-acting injectable antipsychotics, or if you have any other questions within my role as a prescriber, feel free to contact me after this conference. So a few things as far as the acronyms of definitions. First generation antipsychotics are the ones that we have had on the market for many years. The first one was chlorpromazine, approved by the FDA in 1954. We also have haloperidol, discovered in the 1950s and approved in the United States since April of 1967. Those antipsychotics will focus on blocking D2 receptors in the brain, rather narrow action. And they have been on the market, as I said, for a long time until we added second generation antipsychotics that, in addition to or instead of inhibiting D2 receptors, have various other mechanisms of actions, how they can improve health and psychosis in patients with schizophrenia. For acronyms, oral antipsychotics, PO means per os. It's an old Latin phrase, essentially meaning taking medications by mouth. LAI stands for long-acting injectable antipsychotic, which is a medication that is given as an injection and could be administered weeks or months apart. The APA stands for American Psychiatric Association, RTC for randomized controlled trial. NNT will be on one of the slides. It means the number of people we need to treat with the drug or particular intervention in order just for one person to receive the benefits. It was a little bit of a challenging task to compare oral and long-acting injectable antipsychotics, because first of all, there's a whole lot more oral antipsychotics than long-acting injectables. So we don't always get an opportunity to compare the same medication in different formulations. Also, certain trials are designed to be more strictly focusing on particular effect. So a lot of patients don't get to participate in them if they have comorbidities like substance use disorder, personality disorder, maybe they've been treated with particular medications like Clozapine in the past, and they were disqualified to be in particular trials. While in other settings, we had a better opportunity to see how our patients who we commonly see in psychiatric practice respond to medications. So those would be in perspective and retrospective cohort trials. And also the different trials measure different outcomes, so treatment failure through hospitalization, rearrest, suicide attempts. And that's why it's not always to compare the studies on oral and long-acting injectable antipsychotics. The American Psychiatric Association actually recommends that all the patients who are interested in LAIs should be offered that treatment option. And particular clinical attention is always on patients who have history of poor onset on adherence. The APA noticed that patients may experience reduced risk of hospitalization, decreased mortality with LAIs, and overall have the sense of better symptom control and convenience with use of LAIs. The APA also noticed that newer second generation long-acting injectables may be preferred option because usually use a small injection volume and you can space out injections over a longer period of time. The next 5 slides are probably the most critical for you to remember because they represent the summary of many research articles that I will be reviewing in this presentation. So we know that both oral and long-acting injectable antipsychotics are approved for treatment of patients with schizophrenia. We know that patient self-reports and physician estimates of patients adherent to treatment are extremely unreliable. Patients who are treated with long-acting injectable antipsychotics compared to those who are treated with oral medications demonstrated lower risk of treatment failure, rehospitalization, drug discontinuation, gaps in treatment plasma concentrations, lower risk of violence and death. Patients treated with LAIs on transition from oral medications had fewer hospitalizations, fewer inpatient days, fewer ER visits, and overall decrease in healthcare costs. LAIs have been found to be equally effective compared to the oral counterparts and had significant reduction in the incidence of first hospitalization. Also, when we look at second generation long-acting injectable antipsychotics, we know that they commonly are better adhered to over a longer period of time and usually require fewer additional medications to be added on to treatment compared to first-generation antipsychotics in long-acting injectable form or oral antipsychotics. The next study is not so much about the LAIs or antipsychotics, but just to set the stage. We know that the most critical time in transitioning from inpatient care to outpatient care is the first few weeks. And this study reviewed almost 60,000 discharges from inpatient psychiatric facilities and found that more than 40% of the patients did not receive follow-up care within 30 days of discharge. There were also a couple of studies that look on how reliable patients are in taking their oral medications. They used the electronic cap technology, essentially meaning when the patient opens up a bottle, every time there is a sensor that registers the patient as taking their oral medication. So in this particular study, the threshold was 70%, meaning that if 70% of the time, 7 times out of 10, patient opens the bottle when they're supposed to, it means they took their medication. And the patients were asked, well, are you adherent to treatment? And the patients, only 5% of them said that they were not adherent. When they asked psychiatrists if their patients were adherent to treatment, psychiatrists said that only 7% of their patients were non-adherent. In reality, 57% of the patients did not take their medication at least 7 times out of 10. There was another study that looked at 80% adherence. Essentially, if you take medication, if 80% of the time you consider it to be adherent, and less than half of patients treated with oral antipsychotics took 80% of their doses over 4 weeks, and 70% of the patients took less than 20% of their antipsychotic over the same period of time. Another study looked at patients who were considered to be treatment resistant, and they checked their antipsychotic plasma level only to find out that 35% of patients who were considered to be treatment-resistant schizophrenia patients had their plasma level subtherapeutic, and of those 34% had undetectable medication plasma level. So we were thinking that they're in treatment, but treatment-resistant, whereas in reality, they did not really have any medication in their blood to cause any benefit. This study from Finland looked at the LAI medications compared to their oral counterparts and found that there was significantly lower risk of hospitalization and drug discontinuation in patients who were treated with long-acting injectable antipsychotics. This one compared long-acting injectable paliperidone administered once monthly to randomly assigned oral antipsychotics. Those patients were followed for 15 months looking for evidence of treatment failure, such as arrest, incarceration, psychiatric hospitalization, suicide, treatment discontinuation due to side effects or inefficiency of treatment. And there were significantly fewer treatment failure events in patients treated with LAI paliperidone compared to oral antipsychotics, and paliperidone LAI group was superior to oral antipsychotics in delaying the time to first treatment failure. Also, as a secondary outcomes, it was noticed that in 15 months of the trial, the median time to the first psychiatric hospitalization or arrest has never been reached for paliperidone LAI group. However, it was at 274 days with oral antipsychotic group. This study comes from Canada, and they looked at patients who received their first LAI injection and got initiated on the LAI treatment compared to how they did before being transitioned to the LAI. And the study noticed that half the patients who had transitioned to the LAIs had half the number of hospitalizations compared to oral groups, 3 times fewer inpatient days, 40% fewer ER visits, and more than 50% reduction in their healthcare cost. A couple of things that are not on the slide, but in additional analysis, it was noticed that patients who were treated with first-generation long-acting injectable antipsychotics had a much higher incidence of using multiple medications compared to second-generation LAI groups. And also, the number of hospitalization days was reduced even more among patients who were treated with second-generation LAIs compared to patients treated with first-generation LAI medications. And even comparing to first-generation LAIs, second-generation LAI group who had the cost savings at additional $8,000 per year. This study from Europe looked specifically at effects of LAIs on aggressive and hostile and violent behavior, and it conducted a review of cross-sectional chart reviews, retrospective studies, and 2 prospective randomized trials. And across the board, the results indicated positive clinical and anti-aggressive effects of LAIs in psychotic patients with high risk of violent behavior, with particular emphasis that those medications could be a good treatment choice for patients treated in forensic settings. This study comes from Sweden, and as you can see, they looked at almost 30,000 patients treated over a period of 7 years with medications for schizophrenia. And they only look as mortality as the single outcome. And they found out that if patients were treated with LAIs, they had approximately 30% lower risk of dying compared to being treated with oral medications. This graph kind of shows how different groups performed. So the more to the left, the blue line is the safer the medication was from the respect of reducing the risk of death. So you can see second-generation LAIs performed the best. And this one focuses on individual medications. Again, the more to the left, the blue line is the safer medication is considered from the perspective of reducing mortality. And as you can see, most of the agents were LAIs. The only exception there was oral aripiprazole. And the last graph from the same study looked at the counterparts of oral versus LAI antipsychotics. So it's kind of comparing to apples there. As you can see, all the blue bars were to the left, meaning that where LAIs medications were much more effective in reducing mortality in patients treated with schizophrenia compared to no treatment or oral medications. And now, this is the study that looked at probability of hospitalization for any cause 30 to 60 days after the initial hospitalization. And the patients who were prescribed the LAIs had significantly lower probability of rehospitalization for all patients. This one was a retrospective evaluation of 240 men and women, all adults diagnosed with bipolar disorder, schizophrenia, schizoaffective disorder, who were discharged from the inpatient state hospital over a 2-year period. And LAIs had patients discharged on LAIs had significantly longer survival time compared to those who did not, who were not discharged on LAIs. And also, what was interesting, there's a secondary analysis that if the LAI injections could be spaced out further in time in between injections, the survival without readmissions was even longer. Now, this study looked at patients who were considered to be early versus late initiators on long-acting injectable antipsychotics. Essentially, after receiving the diagnosis of schizophrenia, some patients were put on long-acting injectables within the year of receiving the diagnosis, and the second group received the LAI after a year or longer after receiving the diagnosis of schizophrenia. And the early initiators had fewer psychiatric hospitalizations and overall significantly lower cost of healthcare. this is a retrospective review of the discharge of patients discharged from inpatient units that looked at who would be the likely patients to receive LAIs. The study identified 70% of patients discharged from inpatient units who were eligible for LAIs. However, only 44% were actually prescribed LAIs. And the only factor that made a difference was the age of the patient. So the younger the patients were, the more likely they were to receive long-acting injectable antipsychotic. This one was a pretty interesting mirror image study. Essentially, patients were compared to themselves before and after they were switched from an oral medication to aripiprazole once monthly injection. And as you could see, psychiatric hospitalization rates were significantly low when patients were treated with aripiprazole once monthly injection compared to themselves before they were switched to treatment with orals. Now, the next study looked at essentially comparing aripiprazole to itself in oral versus long-acting injectable form, and LAI aripiprazole did just as well as the oral form, so it was non-inferiority study. And this one was pretty interesting study. So instead of randomizing patients, they randomized almost 40 mental health centers in the United States, and half of those centers were asked to consider the aripiprazole once monthly as a primary treatment option for patients with schizophrenia. And the other ones, clinicians were told, prescribe anything you want, including LAIs. And at the results, what we could see that patients who were treated with aripiprazole once monthly had clinically 44% reduction in incidence of first hospitalization, and essentially you needed to treat 7 patients with LAIs to prevent 1 hospitalization, and that is compared to the traditional care that patients receive. Now, this is an analysis of multiple publications, including 5 randomized controlled trials, 4 prospective and 4 retrospective observational studies. And they essentially compared the outcomes of patients treated with oral and LAI antipsychotics. It is interesting that in randomized controlled trials, oral and LAI antipsychotics performed about the same. Some favored LAIs, some favored oral antipsychotics. But then again, please remember that in randomized controls trials, patients go through highly selective process to qualify. And also they have that kind of plush environment where they have much more contact with the treatment providers, have closer follow-up. And we know that the LAI and oral medications have the same active ingredients, so that's why you may see the results that are more kind of similar for the various formulations. But as you move to prospective or retrospective studies, you could see that the bars are much more to the left, favoring long-acting injectable antipsychotics as opposed to oral in various outcomes like hospitalization, relapse, and all-cause discontinuation. And remember that in observational studies, the treatment settings are much more realistic. They're much more resembling the patients reviewed in the study, like what we treat in true clinical settings. And while there could be some lack of control for some confounding factors, it's much more like real life studies. And the very last study I want to focus on is the one that managed to compare first generation long-acting injectable antipsychotics, second generation long-acting injectable antipsychotics, and oral antipsychotics. And what it looked was, the study looked for was how long would the patient stay on antipsychotics, how often they would have treatment interruptions, and also would they need any additional medications in addition to their primary treatment agent to treat schizophrenia. And essentially the study found out that patients who were treated with second generation LAIs had better treatment adherence, were more persistent in receiving treatment compared to oral antipsychotics, while those who were treated with first-generation antipsychotics did not show significant improvement in adherence or persistence compared to oral medications, and also had the need for more additional medications prescribed in order to control their symptoms, even when compared to oral antipsychotics. So I have all the references for you as part of the slide deck, and I guess we have few times for questions. Here's also my contact information.
Thank you, Leon, and thank you, Amy. One question, Leon, when you're talking to your patients regarding the medication and trying to come up with a joint decision, how do you introduce the LAI versus the PO in terms of the joint decision?
Okay, now we're moving away from research and personal experience, but I can tell you that I start with first of all, informing the patient about all the options that are available, because if the patients don't know what they have to choose from, it's hard for them to make the decision. And then I ask them how often they would like to take their medication. Would they like to take it twice a day, once a month, once every 3 months? You may have heard that FDA just approved the medication that could be used once every 6 months. I also focus on possible barriers that patients may have to taking their medication. Some of them could be college students who don't want to tell their friends at the dorm what's wrong with, answer questions like, what's wrong with you? Why do you have to take pills? In this case, injection stays strictly between the patient and the doctor. Nobody else gets involved. I have a bunch of patients who are group home residents or live with families, and they're tired of answering questions. Well, did you take your medication? Are you sure you took your medication? Can we look at the bottle and count your pills to make sure you take your medications? You don't look like you have taken the medications. Maybe I should talk to your doctor about that. Those patients are adults, and they deserve to be treated like adults. And the whole notion of being stuck with the needle or fear of that, I personally find unrealistic. People get injections for whatever reason, and usually it's more of an excuse rather than a true fear of needles.
Yeah, and the second question, Leon, with the older long-acting injectables, there was always the concern about tardive dyskinesia. Would you say something about the newer long-acting injectables and tardive dyskinesia, and how that compares to the newer generation PO antipsychotics?
So the rates for older medications for tardive dyskinesia were estimated at about 5% per year. The new ones could be as low as 0.5%, but the numbers vary a little bit there. It is true that there's overall lower incidence of tardive dyskinesia with second-generation agents, and it's really not related to the form, so oral or long-acting injectable. There's no separation there as far as I'm aware of. But even from the clinician's perspective, we have to do periodic assessments like AIMS, which is abnormal involuntary movement scales. And the treatment guidelines say that if you have a patient who is on first-generation antipsychotic, you have to do those twice as often compared to patients who are treated with second-generation antipsychotic. So it's a little bit easier on the clinician as well, particularly now in the time of COVID, when a lot of patients prefer to have telemed appointments as opposed to coming in persons. So it's a little bit easier on the clinician as well.
Thank you. And Dr. Cohen, I know that the SMI Advisor, you're focusing on bipolar, major depression, and individuals with schizophrenia. What would you say about the first episode psychosis programming and prodromal, and how that might fit in with your tasks within the SMI Advisor?
Right. So SMI Advisor does do some work on those who are in their first episode. We don't do too much on the high risk group, but we do quite a bit on first episode psychosis. And last year we held a large conference on first episode psychosis, really dealing with the whole team and adjustments being made during COVID. All of those webinars are available on demand on our website. And we've worked closely with PepNet and NIMH and other groups who are doing good work specifically on early psychosis around the country. We know that there are specialized groups doing work in this area. And so we leave the heavy bulk to them, but have partnered with many of them to bring some of that forward to our audience as well.
Great. And one last question for both of you, and that is, one of the impressive areas within the SMI Advisor is the Clozapine landing page. And we know that Clozapine is underutilized for years. We've been championing the use of Clozapine and trying to make it more visible across the country. Dr. Cohen, would you say what SMI Advisor is doing to try and bring visibility to the importance of Clozapine?
Right. So, I mean, as you mentioned, we have our landing site, the microsite. We also have the listserv where people can ask questions, and it's moderated so that there are experts who are answering the questions, but also a space for people to share with each other. One of the things that we're finding is very topical right now is the move to the new REMS system. And many physicians are very worried about the burden, understandably, moving to the new REMS system. We're actually going to have a webinar to help people with that on 9/29, which we'll be pushing out. And we're going to have some tip sheets on the move to the new Clozapine REMS system. So we know that people are worried about that. It's unfortunately another barrier to getting people to moving to Clozapine. So we're trying to help people over this change to the new Clozapine REMS. And Leon, you may have more to say about that.
No, I think you got it covered.
Okay.
Well, thank you. And I guess we have time for one more question. There was a question in the chat from Dr. Burnett, and they moved her to Maryland. That's interesting. I think Mary is from New Hampshire, but Leon, can you comment on Abilify MySite and whether there are cases that this should be covered by Medicaid?
Mary, thank you for the question, and I think MD stands for medical doctor, not Maryland. Just but
no, this was spelled out Maryland.
Yeah, Mary, unfortunately, I don't have a lot to say about Abilify MySite. I personally have never used the technology for that reason, and in Nevada, frankly, I don't even know if it has any coverage by Medicaid. I know we are blessed in Nevada that all of our long-acting injectable antipsychotics, at least on the preferred drug list, and that is certainly makes our life and the life of our patients a whole lot better. But sorry, I can't tell you more.
So with that, Amy, Leon, thank you very much. It's been a good discussion. Appreciate it.